18. So you all are like, do you have any doubt with this question? Because this is incomplete situation and we have just discussed about this ALL and AML, right? So I hope there's no problem with this because you need to know because multiple malam discuss AML, AL, all things discuss. I have again attached this chart as well. So that's what I'm okay. No, no, doctor, we just started. We just started, okay? So here, pain during 18 talking and touching one-sided maxillary tenderness, most likely diagnosis. They have given trigeminal neuralgia, dental abscess, and a woman with several episodes of burning facial pain on the one side, previous episode of headache, tenderness and palpation of maxillary area. Diagnosis, okay. This is the thing that they have given. So what do you know about? So or you all choose it as a trigeminal neuralgia, right? Trigeminal neuralgia. So, what is this trigeminal neuralgia? So, trigeminal neuralgia is a recurrent unilateral brief shock-like pain you can see, right? Then it involves one or more divisions of the trigeminal nerve and caused by demyelination or neurovascular compression, right? So, assessment is request imaging to exclude the structural cause, and imaging is especially important if there is a sensory loss which suggests trigeminal neuropathy, right? And ask the dedicated views of the trigeminal nerve and ganglions. So the management, drug therapy is the first line, right? So what is the drug therapy that we can use in here? What is the type of drug therapy that you can use? Tell me the first line drug. This topic, the trigeminal neuralgia, has repeated on May as well. Quickly answer, doctors. What is the choice of the drug that we are using here? Trigeminal neuralgia. Okay, here we have what? Carbamazepine, right? Carbamazepine, oxycarbazepine, and the second line, pregabalin, right? Pregabalin. So when you should refer this patient, all this from the TG, okay? If there's a poor response or intolerance to adequate drug therapy, loss of efficacy, diagnostic uncertainty. In that case, you have to refer this patient, and we have surgical options under a special setting. So microvascular decompression, percutaneous rhizotomy, and stereotactic radiotherapy, right? Or gamma knife. These are the other options because these surgical options after referral. So this is the indication for the referral, and this is the drug therapy. Drug therapy is the first line treatment, and this is how the trigeminal neuralgia is present. Right here. A scenario: 53-year-old man present with the ED, worsening of pain along his lower left mandible. The pain is incredibly intense, paroxysmal in nature, and lasts for a few seconds to minutes. The pain is triggered by shaving and brushing his teeth. However, in between episode, he has no residual abnormal sensation. His medication history is significant or hypertension, and he has 40-pack years smoking history. On examination, his blood pressure 140/85, pulse 75, SpO2 98, and light palpation of the lower mandible in the patient. Suddenly, means pulls away in patients and pain, and describe the continuous dull ache lasting approximately 60 seconds in the area. The cranial nerve examination performed and otherwise normal despite hesitancy from the patient, not allowing the area to touch again. Right, so they're asking which one of the most appropriate. So carbamazepine, very important, okay? So patient has a trigeminal neuralgia. So yeah, trigeminal neuralgia, the clinical scenario they're explaining. The exact pathophysiology is not known, but the patient vascular compression due to trigeminal ganglion has been implicated. The pain response to medication used treat neuropathic pain about 70% of patients, and traditionally the carbamazepine is the first line, right? Okay, so neurological referral may be indicated if MRI brain image suggestive of intracranial pathology such as the vascular compression or trigeminal ganglion mentioned above. Okay, so remember carbamazepine, very important. This is all from TG, very important. Okay, next question. Okay, I'll mark the questions. Okay, now tell me how cluster headache is present. How cluster headache is present. Quickly tell me. Quickly, like give me an idea how what are the clinical features, how cluster headache is present. How these cluster headache present? Tell me, doctors. Cluster headache, what are the features of cluster headache? Okay. Yes, severe unilateral headache, right? And patient can be associated with the autonomic symptoms, right? Autonomic symptoms like what are the red eyes, right? Runny nose, then lacrimation. Those are associated, and you can patient is having the retro orbital pain, right? Orbital pain is very severe orbital pain patient can associate it with, right? Then this episode is lasting around 115 to 180 minutes, right? So yeah, like that. So these are attacks, right? Yes. Then how this migraine present? Migraine. What type of headache is there? Migraine is a throbbing and pulsating headache, right? It also usually unilateral, right? Usually it can last 4 hours to 72 hours, right? 4 hours to 72 hours. And like other features, photophobia, right? Phonophobia, aura. In some cases you can see, right? Nausea, vomiting can be associated, right? Okay. So that is something different. So you should know how to differentiate each of them, right? Okay, so next one, hypercalcemia, vitamin D normal, TSH normal. What would be the next investigation? PTH, what do you think? Why PTH? Why PTH, doctors? So what do you know about this hyperkalemia? Sorry, not kalemia, hypercalcemia. What do you know about hypercalcemia? So first of all, you need to know how this calcium regulation is doing by our body, right? So how it going? So calcium is controlled by three main factors, right? Parathyroid hormone, vitamin D, and bone turnover, right? Bone turnover. So these three mechanisms are the one that control the calcium metabolism in our body. So what is the action of this parathyroid hormone or parathyroid hormone? So what is the action? So it increase the calcium resorption from the kidney, then increase the bone resorption, then increase the vitamin D activation and increase the gut calcium absorption, right? It has a power to increase the vitamin D activation, right? And all together they are raising the serum calcium, right? So pathophysiology of hypercalcemia, right? So we know the mechanism, right? Resorption from kidney, bone resorption, and we have activated vitamin D that can increase the gut absorption, gut calcium absorption too. So if something is increasing these three mechanisms, that can lead to the hypercalcemia, right? So increase bone resorption, increase intestinal absorption, and reduce renal excretion. So these are the three things that can be associated with what associated with the hypercalcemia, right? Okay, so okay, if you find out there's an increased level of calcium, so what you need to know, you have to find out what is happening, right? What is happening? So we have primary hyperparathyroidism, right? That is the most common outpatient cause, the most common cause. So what is primary? Primary mean the gland itself, right? Always the primary means the gland, right? As the associated gland. So parathyroid gland. The problem is parathyroid adenoma, right? Parathyroid adenoma, right? Okay. Parathyroid adenoma. So excessive parathyroid hormone. So what is happening in here? What is happening here? If there is a adenoma and it can produce the excessive parathyroid hormone, right? That can lead to the increased osteoclast activity, the bone breakdown, increased renal calcium reabsorption, and increased vitamin D activation, right? So result in chronic to mild moderate hypercalcemia. So this parathormone level is high or inappropriately normal, right? Inappropriately normal, right? Okay. So like that. Okay, then. Okay, and now tell me, Okay, here parathyroid. This is management. If there's a parathyroid, here yes, parathyroid hormone. Definitive therapy is the surgery treatment, because if there's adenoma present, what you need to do, you need to remove it, right? So definitive treatment is surgery, which cures 95% cases and has low morbidity. A watch and wait approach. There's another one is watch and wait approach can considered instead of surgery in patients who are 50 years or older and have total serum calcium concentration corrected albumin lower than 2.9, normal kidney function, and no nephrolithiasis or nephrocalcinosis, and bone mineral density is higher than minus 2.5 and no symptom. This is something else. So if it is a primary hyperparathyroidism caused by this adenoma, you have two treatment, watch and wait, and the definitive surgery, right? So you need to know what are the indications that we are going with watch and wait, right? Then other than that, we have malignancy associated hypercalcemia, right? Because there's a mechanism, as example, like lung cancer, breast cancer present, they can release, they can produce parathyroid hormone like peptide, right? These are not parathyroid hormone, but they are acting at it as a parathyroid hormone. So they are acting fully as a parathyroid hormone, and that can increase the calcium level from these above three mechanism, right? Because the function is same, but the structure is only the different thing, right? And other than that, from this, there's a cancer presence, so bone metastasis can be present. Because of that, direct osteolysis can be seen. That also can increase the hypercalcemia, right? Then other than that, other features like vitamin D excess. Vitamin D excess mean increased gut absorption of calcium, right? Vitamin D excess mean higher vitamin D level activated by this parathyroid hormone, and it can increase the gut absorption, right? Due to excess supplementation, granulomatous disease, or reduced renal excretion, thiazide increased calcium resorption, dehydration was hypercalcemia. So these are the features or other things. Okay. So usually parathyroid, the actual hormone dependent in primary hyperparathyroidism and tertiary hyperparathyroidism, right? So then we have parathyroid independent. That means the problem is not with the parathyroid hormone like cancer, this vitamin D, immobilization. You can remember it as like that. Okay, vitamins trap. Just give it a read, because other diseases like sarcoidosis, neoplastic related diseases, rhabdomyolysis, like these diseases also associated with the hypercalcemia, but it's not the mechanism from the parathyroid hormone. Okay. So what are the clinical features that you can see in here? Stones, bones, groans, psychiatric overtones, right? So everyone know how it presents: renal stone, bone pain, constipation, abdominal pain, polyuria, confusion, right? Depression, those are the associated symptoms, right? So stepwise investigation, you have to confirm the hypercalcemia first, then you have to check the parathyroid hormone level to check whether this is parathyroid dependent or independent, right? So after checking the parathyroid hormone, if the parathyroid hormone high or normal, high or inappropriately normal, so you can think about primary hyperparathyroidism. The problem is the adenoma, right? If the parathyroid hormone low, that means there's nothing associated with the parathyroid hormone. You have to find out the other cases, right? Other cases like that. Okay, so the treatment also I will explain. The initial rehydration, the acute severe hypercalcemia, if it is more than 3, often cause dehydration and electrolyte depletion, so leading to the deterioration in kidney function that increase the serum calcium concentration further. Rehydration with sodium chloride infusion is essential, right? Sodium chloride 0.94 to 6 liters by intravenous infusion over 24 hours, right? So very important. Other than the additional treatment, what are those things? In severe hypocalcemia, child does not respond to adequate rehydration. You have to go with the specialist advice. For the pediatric, for adult, severe hypocalcemia has not responded to the initial rehydration, you can use intravenous bisphosphonate infusion to temporarily lower the serum calcium concentration before starting the bisphosphonate. So, before starting bisphosphonate, take a blood sample to measure the patient's parathyroid hormone concentration to help the determine the cause of hypercalcemia, right? Because then only you can get an idea it's a dependent or independent case parathyroid, right? So these are the options. The first line, the solendronic and pamidronate, you can give as additional treatment if the initial hydration is failed, right? Initial hydration is failed. Um, yeah, acute life-threatening hypercalcemia, consider parenteral calcitonin, salmon in addition to the bisphosphonate to achieve the more rapid effect. So you can give calcitonin salmon 100 international units subcutaneously as well. Okay, so yeah, that is a general one. Other things I'm not going to read because that is got into different diseases. If it is a vitamin D toxicity, how it present, and if it is a granulomatous disease, what to do, like that. Okay, if it is associated with the cancer, also I have attached. You can give it a rate because today topic is not the cancer related one. Okay, because in previous months, I think March and April, we got the cancer related hypercalcemia, right? Here the hypercalcemia, vitamin D normal, TSH normal. What to be next investigation? So you already find out hypercalcemia, then you have to get idea about is it parathormone dependent or independent because you have to understand if it is the due to the adenoma or not, right? Then after, if it is dependent, you can do the further test for the parathyroid adenoma, right? So we have that question answered because in the May also they have asked that question. I will explain once we get the question. This why it is there. Okay. So the next question. So give it a read those things. Okay. Because important parts are highlighted. So target esophagus treatment. So what do you think? What is this? What is this, doctors? What is tortoise esophagus? So what is happening there? So what is it, doctors? What is happening there? What is happening? 1 minute. Okay. Okay. What do you know about this tortoise esophagus? What is happening there? Okay. So, no, that is different, doctor. So, tortoise esophagus, this is a new topic. So, it's a serious problem, came from the chronic achalasia. It's a disorder that stops from food pipe from relaxing, right? Over the time, the pipe get very wide and twisted, making it hard to swallow. It's a rare disorder, affect about 1.63 people over 100,000. It's a big challenge. No. So, what are the key features? Tortuous esophagus usually comes from untreated or long-term achalasia, right? The condition make the food pipe very wide and twisted, make digestion hard, right? So this is a complication from long-term untreated achalasia, right? Long-term untreated achalasia, right, doctors? It. Yeah. Okay. So studies show no need that part. Okay. So here I'll show how this came, how this come to here. 1 minute. It should not be here. It's fine. I'll remove it. Okay. So we'll do this question. We'll do this question to get an idea about 38-year-old man present to GP clinic gradually worsening dysphagia and frequent regulation of the food while eating at night. Over the last few months, he had a dropped 2 pound size even though he has not been trying to lose weight. He otherwise has an insignificant medical history. He is referred as specialist and undergoes endoscopy to subsequently rule out malignancy. He's sent for the esophageal manometry, and which indicate has excessive lower esophageal splinter tone and intermediate periods of paranasophageal pressurization. So when asked, he explained that he want the procedure, does not want to repeat interventions. He also want a procedure that is a minimal side effect. So which one of the following most appropriate plan of man? This is what is the diagnosis in this given scenario, doctors? So what is the diagnosis in this given scenario? Tell me what is the diagnosis? Yes, achalasia, right? Achalasia. Right, doctors? So, why he's going with the laparoscopic hematoma? Let's see. This patient has achalasia. There's a number of factors considered which will help to decide the most appropriate plan of management. These factors include the age and general state of health of the patients and manometric finding. When the considering the treatment option, the patient must be counseled that none of procedure will be totally free of side effect and further correction might be required in chosen procedure. Right? Okay. So, however, some procedures will have less side effect than others, and some will have better likelihood long term. So, per oral endoscopic myotomy, incorrect. Why this is a first line option for the surgical management of achalasia. However, it has significant risk of gastroesophageal reflux disease. So, post procedure for this reason would not be offered in this case. Right. So pneumatic dilation of the esophagus. This is a management option for recommended people with type 2 achalasia, and however, it is more favorable response in people over age of 45 and those of female sex, right? There are high risk, high likelihood that this patient would need further interventions as remission only 5 to 10 years, right? So then, Botox injections a non-surgical management for achalasia, while it is possible management option for type 2 and generally recommended for patient not fit for the surgery or as a bridge for more definitive therapy. Okay, laparoscopic helamiotomy. This is an option for the surgical management of the achalasia. This patient type 2 uh, and would be classified as level 3 as per Eckert score. I'm not going to explain the achalasia, the stages and those things, but I want to give an idea about the treatment. Okay, the recommended management of type 2 achalasia is a pneumatic dilation, helamiotomy or POEM. So he has a younger and otherwise healthy, so good candidates for helamiotomy. So usually they are just asking is management, then you have to think according to the given factors, right? The patient's age and severity, those in. Then fundoplication. This is a surgical management offered for patient with gastroesophageal reflux, right? Okay. Okay, I'll show achalasia types only to get an idea. Yeah. If we get the topic, I will explain. Okay, I can attach it to you to get an idea. Okay, about this treatment and all. I don't know, sometimes it's very hard to deal with this. So now I'll attach here. Okay, and this is about some treatment for achalasia. Okay, let's see the link between achalasia and esophageal distortion, right? Okay. So achalasia is the biggest reason for this twisted esophagus. In achalasia, the nerve that can control muscle movement get damaged. This makes hard food to move down, causing the esophagus to stretch, right? So this stretch puts a lot of stress on the tissue and it can lead to this loss of muscle contraction and higher pressure in the esophagus, and the esophagus started bend and stretch. Okay, there's a no proper guideline for this one. This is I think there's a UK guideline I got. Okay, there's a no guideline or nothing mentioned about this one. in Australia and no emergency as well. Okay, so but I found out this is UK guideline. So mechanism lower esophageal sphincter dysfunction. The lower esophageal sphincter control the food. We all know that in a healthy boy open to let food through, but in the distended esophagus does not open right. Right, so this block the trap and fluid and liquid because people can't get to the stomach. Then what are the primary option for the tortuous esophagus treatment? Treatment for a twisted esophagus is complex. Standard procedure are hard because of the shape. So we often try to clear the blockage first. Okay, if it is a blockage there, we have to clear it first. Then to damage what surgery can do, like esophagectomy. How does this twisted achalasia lead to respiratory issues? This is the another case that can lead to the respiratory issue. Okay, twisted esophagus can hold the food, and this can increase the aspiration, and it can burst this respiratory. There can be a respiratory problem, right? Aspiration pneumonia, those can be presenting, can be seen. Okay, so this tortuous esophagus, right? It's like a dilated and twisted esophagus, right? Dilated and twisted esophagus. Let's see, we can find this something, the good picture. It is esophagus, not meaning. Yeah, can you see it's a dilated? 1 minute, let's find out a better picture. Here, this is the one. Here esophagus showing the dilated tortuous esophagus consistent with, let's see what they have given. Because this time some topics I don't know, but they are here end stage achalasia. Here, can you see? I'll attach this picture as well, the dilated one, right? So what do you think the treatment should be like if this is like dilated, twisted, present in esophagus present? So what do you prefer? I think surgery would be the best, right? Surgery would be preferred, right, doctors? What do you think? The surgical management should be preferred because the only option we got that, because we can still think about this, because the thing is anyway this seems like a very serious situation, right? Very serious situation, and better to do the surgical things. But I will try to find something else, but actually couldn't find a proper guideline. I went through like multiple guidelines and they have not given a proper one. Proper one. Okay, like that. So mostly this is associated with the long-term untreated achalasia. So it can see the after barium solo, you can see the dilated, this tortuous, enlarged like this, enlarged esophagus, right? Esophagus, and the treatment. So it's a achalasia associated because of that, and this is complicated one. So I think better to go with surgical correction, because like there's a no proper guideline to tell if it is this you can go with that, like there's a no guideline. That's what we can generally get an idea, because of the severity and everything we can go with that, right? So that's what I have attached the treatment for the eclampsia. In here also we can think about the laparoscopic myotomy. It's a better option, right? Surgical management, yeah, like that. So I hope you get an idea, because some questions there's a no proper guideline in those things, that we have to find, we have to use some updated guideline, especially the surgery questions, right? If you are like if you have any idea, if you have the proper idea about those guidelines that they also I have explained about it, because we don't have a proper guideline for this surgery. In that case, better to use e-medicine is the first priority I will give. Other, if e-medicine also not mentioning, that you can use uh, sorry, you can use the other updated guideline, teach me surgery up to date or whatever they are available with the updated guideline. Okay, so HIV positive 55 all person with right flank pain, red blood cells in urine, most appropriate initial investigation, intervenir given. So CT, KUB, non-contrast CT, ultrasound, cystoscopy. So what do you think? They're asking most appropriate initial investigation. And what do you know? What is happening in here? A person with flank pain and hematuria. Hematuria present. So painful hematuria. So what you should think about in here, painful hematuria. It can be what? It can be infection or it can be stones, right? But here, what you know about the internovir association? What is associated with internovir? The stones, right? The stones associated with the internovir here. Drug-induced renal calculi represent 1 to 2% of all renal calculi. In the last decade, drug use for the treatment of HIV-infected patients have become more frequent cause of drug-containing urine calculi. Among these agents, sorry, the protease inhibitors are well known to induce kidney stones, especially indinavir and atazanavir, and more recently darunavir, right? So urolithiasis is attributed to the other PIs and also been reported in the clinical cases such as those during non-PI cases. Okay. So here again I have attached among antiretroviral. So intervenir has the high potency to cause these urolithiasis, right? Urolithiasis. So now tell me what should be the answer. What should be the answer? Patient is 55. What should be the answer? Okay, here do you remember this chart? Okay, history and examination, and microscopic hematuria and macroscopic. If it is macroscopic, you are directly going with the CTIP. Even if it is a microscopic hematuria, and according to the risk stratification, our patient, if it is microscopic, okay, age is 55, so age more than 50 years. So even here our patient is having risk, so risk factors present anyway, he is going to this CTIVP, right? CTIVP. Right, doctors, I hope it is understandable, but here you have to always exclude the exclude what? Exclude UTIs. Okay, exclude the UTI as well. So from given these three options, they are. It seems like they are trying to give a hint about the investigations, like main investigation, like imaging and those things. So because of that, we can go with CTKUB. That is the most important thing.
But Dr. Sitara, in the
Yeah.
guideline in the flow chart, it's written
Okay.
either CT, IVP, or ultrasonography. Can you revert that?
CTI, doctor, I have showed in previous when I was discussing the hematuria question, I have shown they have clearly mentioned CTIVP is the best one. I have not attached it again because already we have discussed it. Have you not seen the previously we have discussed what is hematuria, the causes and everything hematuria discussed. So in that case, I have explained about the CTIVP. Okay, so please make sure those points are very important. Yes, it's day one, yeah, right? Yeah, it's different, but go with CTIVP because we don't know the recaller, the way of given this, right? So go with CTKUB and CTIVP. Other than what are the other names? CT Eurogram, right? I that day I have shown that how they can ask with different. different things. So non usually CTIUB, no, the same, right, doctor? CTI, yeah, it's the same, right? I mean CTKUB. Usually CTKUB mean they have not mentioned like here I contrast or not, right? KUB mean anyway kidney ureter bladder. So yeah, without contrast, right? We are using. But if it is like given better one is what? Better one CT CT IVP like here that they have mentioned IVP intravenous or CT urogram with the what with the contrast, right? With the contrast doctors. Okay, so the here the given one is the same. Non-contrast CT and CT KUB, that is same. Okay, the same thing, not different. Okay, you get the idea, right? Doctor Society IVP. So in the name IVP, that mean IV is present, right? IV present. Right, doctors? Yeah, but here you can see non-contrast is better because it's clearly given a hint about Indonavir, right? Indonavir, because that they are giving a hint about the stones, right? So stones are given, so we don't need to have the IV contrast, right? So usually IV contrast is very important in the check-in of the like excluding cancer and everything, right? But in here the given scenario, CT. Yeah, skin most appropriate initial investigation. So non-contrast CT is a better one, right? It's depend on the scenario. Yes, CT IVP different, then follow the same for painless hematuria. So if it is a painless hematuria, so you can go with CT IVP. CT IVP with contrast. Okay, with contrast. And if you are very like if you have properly read it in the e-medicine also, they have given two things. The non-contrast one for one answer and other case they have given the CT urogram. It's fine. The CT is the best. Okay, CT is the best for the initial. But if it is a painless, check if this is CT IVP present. If it is not, still you can go with CT KUB. Okay, because CT is the best option as the initial investigation. Okay, because not the ultrasound, right? Okay, I'm moving to the next question. Is it understandable, right? Because here they are very clearly given a hint. So you don't need IV, right, with the contrast. Is it okay, doctors? Is it okay or not? Please check the hematuria note, then you will understand, okay? Is it understandable or not? Tell me, doctors. Quickly, we have to move. Doctors? Yes, right? Yeah. Okay. So go through the question that I have attached in the previous file, the hematuria. So then you will understand, okay? So we'll move to the next question. Patient drowsy and confused, taking suclofentixol, olanzapine, and lithium, now has fever, hypertension, and muscle rigidity. Which investigation confirms the diagnosis? CK, urine drug screen, CT head. Then next question is neuroleptic malignant syndrome, best diagnosed method. So two different recallers. So what do you think? So what do you think, doctor? The first question. So what is it? Mm-hmm. Okay, we'll do this question. I'll do this question. Oh no, I have not attached the question. No, it's fine. I'll show a question. I have attached only this part. So yeah, so then I will explain about neuroleptic syndrome. So what is neuroleptic syndrome? That is happening in here. Yeah, so you can remember the neuroleptic syndrome from one of this picture. Okay, so you can remember it as MATE. A mean mental state. So altered loss of consciousness, drowsiness, the autonomic features, tachycardia and hypertension, then thermoregulation, hyperthermia, temperature more than 39 is very much associated with the hyperthermia. Then extrapyramidal symptoms like bradykinesia, rigidity, and tremors. This picture clearly given a proper idea about the clinical presentation, right? So, what is neuroleptic malignancy syndrome? It's a rare but potentially life-threatening reaction to the antipsychotic medications characteristic by fever, muscle rigidity, altered mental state, and autonomic dysfunction, right? So, what is the management? Okay, if they ask in immediate management, patient is taking risperidone and patient present with these made features, made symptoms that I have explained earlier. Made symptoms, these people presented with that. So, what you need to do initially? Okay, you are suspecting what? In the management, what you can do? Is it given something? No, in the I'm asking about the treatment, like how, what you need to do initially. Here, the immediate discontinuation of the causative agent, typically the antipsychotic, is the first step in managing neuroleptic malignancy syndrome. Neuroleptic malignancy syndrome. Just discontinue because neuroleptic malignancy syndrome is a severe case. So here, sorry for that. So here, if it is a severe, is a serious situation, so you are not ready, so doing anything. If it is only that extrapyramidal side effect only, you can follow that the reduce and the change to another drug that pathway. But here, this is a neuroleptic malignant syndrome. It's a life-threatening emergency situation, so you have discontinuation of the this causative antipsychotic, right? So supportive care including cooling measures because this is associated with the hypothermia and fluid resuscitation is crucial in the management of NMS, right? NMS. Okay, so here these symptoms, the MAID symptoms, normally occurs 2 weeks after the first dose. The key aspect of management is discontinuation of the antipsychotic drugs, right? Here, again, I have mentioned like how these symptoms are present. Extrapyramidal side effects led by rigidity, then bradykinesia, dystonia, abnormal movements, postures, tremors, temperature, hypothermia more than 39, autonomic features, tachycardia, hypertension, labile blood pressure, sweating, tachypnea, the central nervous system involvement, drowsiness, confusion, altered mental status, coma, those things can be present. So abnormal investigation finding true not specific in neuroleptic malignant syndrome. Serum creatinine kinase concentration more than 3 times in upper limit of normal. Leukocytosis and low serum iron concentration. Diffuse globin on an electroencephalogram consistent with metabolic encephalopathy. Cerebrospinal fluid examination, lumbar puncture may be normal or have slightly raised protein concentration. CT and MRI of the brain are normal in neuroleptic malignant syndrome. Right? Okay, and we have something called the diagnostic criteria. Here, yes, diagnostic criteria here. So, diagnostic criteria, we have major criteria and we have other criteria. So, diagnosis of neuroleptic malignant syndrome based on the clinical finding, the criteria are not well defined. So, these diagnostic criteria, neuroleptic malignant syndrome. So, major criteria must have all three: exposure to dopamine antagonist drug, severe muscle rigidity, hypothermia, right? All three should be there. So, other criteria at least two of tachycardia, hypertension, labile blood pressure, sweating, raised serum creatinine kinase, leukocytosis, and dysphagia, tremor, all that consciousness state, mutism, and the incontinence, right? So treatment here, stopping the causative agent, supportive care, prevent complications like thromboembolism, rhabdomyolysis, aspiration pneumonitis, exclusion of other medical, toxicological, psychiatric disorders, right? An antidote such as bromocriptine is sometimes required for severe prolonged neuroleptic malignant syndrome, right? Yes, bromocryptine. Yeah, that is the way. So yeah, in here in the given options, so the Western is we can check the CK, but to confirm the diagnosis, what you need to confirm the diagnosis. To confirm the diagnosis, I think, and here usually it's based on the clinical finding, the diagnosis, right? So all exposure to dopamine, severe muscle rigidity, hypothermia, and these things. This is the diagnostic criteria. Other than that, others are non-specific. But given in these all things, these all three, the creatinine kinase, CT, and those things, the better one go with CK because it can be associated with this rigidity and those things, right? So in that case, we can go with CK. This question is kind of weird though, because the problem means like they are given all the non-specific things, right? Non-specific investigation here, and they ask as to which confirm the diagnosis. Yes, EK is elevated, that's true, but that is not a specific, but the mainly to diagnose it, you need to have the clinical presentation, right? Clinical presentation. With the clinical presentation, we still can. Yes, it's a minor criteria to confirm. Actually, to confirm the diagnosis, like this is the diagnostic criteria, right? Criteria here, criteria should be there, but we don't know the question. But given in options, we can go with CK. But for me, I feel like if like the critically, if these three of present, that can be the best for the diagnostic, right? Exposure to dopamine antagonist, severe muscle rigidity, hypothermia. Okay, in that case, I think they will give these three in the stem. They will give these three in the stem, and one criteria from me as example. And the leukocyte and the tremor also present, then they can ask what you can use to confirm, because then already three criteria is fulfilled, and here and one criteria also here, the tremor, and other than in that case you can go with the raised serum creatinine kinase, right? Raised serum creatinine kinase. Right, doctor. So if we can think like that, yes, if we can think like that, this can be working, right? According to this one. Think like that, okay? Otherwise, there's no criteria as CKs to diagnosis, okay? Next one. 1 minute. Sorry. Erythema diagnosis. So, what is this erythema? What do you know about this erythema? Erythema. We have kind of new topics also this time, right? Every time they are giving the new topics here, also mostly related with the dermatology. What do you know about this erythema? Okay, so what do you know about erythema? We'll do this question and we'll come back. 68-year-old woman present to the GP with 2 week history of mildly itchy rash under her breast. She is otherwise in good health and has no significant medical history and do not take any regular medications. Then, on examination, she appears well with vital signs within normal limit, and there are well demarcated reddish brown, slightly scalpy patches in the inflammatory folds bilaterally. A wood lamp examination revealed coral red fluorescence in the affected area. Then they are asking which one of the following is most appropriate first line treatment for the condition. So, what do you think? So, type your answers here. Type the answer. Type the answer quickly, doctors. What do you think? Quickly answer. Oh, sorry, you can't see the picture. Answers, right? So now tell me the answer. These are the answers. Just give it a try. Give it a try. Okay. Mm-hmm. Okay, let's see. Okay, the patient's presentation is consistent with erythema, right? Okay, it is superficial skin infection caused by Corynebacterium minutism. The characteristic features include the well-demarcated reddish-brown patches, slightly scaly and mildly itchy intertriginous intragenous areas, right, such as under breast, under groin, and the between the toes, right. The coral red fluorescence under wood lamp examination, right, very important. Remember coral red under this fluorescent wood lamp examination. The most appropriate first line treatment for localized erythema is topical fusidate sodium. Topical fusidate sodium. This is antibiotic. This antibiotic is effect against this organism, right? Organism. So, yeah, would be applied this and would be applied as fusidate sodium 2% ointment topically twice daily for 14 days to warm patient that recurrence is common without addressing the preventive measures, right? Do you get the idea? So here erythema is a superficial skin infection that caused by Corynebacterium minutism and frequently found affecting the intravenous areas. The topical fusidate sodium is the effective first-line treatment, right? Wood lamp examination revealed the coral red fluorescence in erythema lesion. So these three are the main three important things you need to remember, right? You need to remember. Here, can you see the other options? We have different tribes, interdigital between toes, intragenous erythema, armpit, groin, under breast, and umbilicus, then generalized one on the trunk. Right here, this is how woodlight fluorescence can see. Okay, so how to diagnose wood lamp? Now, skin examination, the long wavelength ultraviolet causes erythema, fluorescence coral pink color due to the chlorophyll released by the bacteria. Okay, like that. Then swab or skin scraping microscope with periodic acid shift. And these methanamine silver or gram stain may be revealed the gram positive filamentous rods. And these C minitosim, right? And if you want more details, you can give it read from here the Dermanet. This is from this part from Dermanet, okay? And this is the one of emergency question. They have given the typical presentation, and they are asking the diagnosis. So wood lamp examination you can do, right? Wood lamp examination you can do. It, yes. Okay, is it understandable? Yeah, these are new topics. Yeah, event is also there. But some topics we can't find. I think not only this question, there are more question for this topic. Please do those as well, okay? So very important. Next one, patient present with vomiting, abdominal distension and groin swelling. Previous history appendectomy many years ago. What is the next best step? Surgical exploration of the groin, ultrasound of the swelling, CT abdomen. What do you think? Okay, we'll do this question. 74-old woman attend to the ED with 2-day history of nausea, vomiting, and constipation. She has not opened bowels for 5 days, passed any flutters for the 2 days, and has started to have episodes of cramps like abdominal pain. She has a medical history of Parkinson and with the appendectomy 30 years ago. Her medications include simvastatin and aspirin. On examination, she appears uncomfortable. Her vital signs are within normal limit, and examination show that the abdomen is distended, soft, and with no area of tenderness. So, which one of the following is most appropriate? What do you think, doctors? Answer for this question first. Mm-hmm. Yeah. Okay, this patient almost certainly a small bowel adhesive obstruction. Adhesions are common cause of small bowel obstruction and previous appendectomy, often decades earlier. Is often the trigger. The management of such problems should first of all focus on clinical picture, and if some form of radiological investigation is considered, which imaging would be the best appropriate, whether resources are limited. A plain abdomen radiograph will usually provide sufficient information for the case of suspected perforation, small bowel obstruction, and the presence of foreign body. So abdominal ultrasound is frequently used investigation in emergency department and often more readily available than CT. In case of focused abdominal pain, particularly right upper quadrant, the pain is suspected gallstone disease, so sufficient diagnostic information will be obtained through ultrasound. However, in most cases, the acute abdominal pain, more useful information will usually be gained from the CT radiography. In this particular case, the plain CT scan will confirm the diagnosis and identify the likely cause of site of obstruction, right? Yeah. So here, plain CT will confirm the diagnosis and identify the likely cause of the site of obstruction, right? Then okay, give oral contrast would be erroneous, as the patient may require prompt surgical intervention, and oral contrast is an obstructed gut would increase the risk of aspiration, right? That's why we are not giving IV contrast, CT, right? Okay. So a plain CT is a simple investigation to perform the case of suspected intestinal obstruction where both sides are in nature obstruction can be identified. Okay. So what is the answer for this one? 72-year-old man present to the ED with a 2-day history of absolute constipation, preceded by 1 month history of increase in constipation. What? Answer is CT. Answer is CT. For which question? Answer is CT for the e-medicine question. First, we will discuss, doctor. Okay, then we will. Anyway, after this discussion, I'm going back to our question. Okay, so I'm discussing these things to you to gather information. Okay, otherwise, no point of adding e-medicine, right? Okay, so 72-year-old man. E-medicine one, yeah, CT. Here they have clearly mentioned the plain CT will confirm the diagnosis and identify the likely cause of site and obstruction in this particular case, right? Okay. Okay, so read this question. Read this question and tell me the answer. 72. Emergency department, 2-day history of absolute constipation, proceed by 1 month history of increase in constipation. On examination, On examination, his abdomen is distended and soft apart from the localized tenderness in the right iliac fossa. Nothing abnormal can be felt on the rectal examination or no fecal matter can be felt. A plain abdominal X-ray shows the gas in distended large bowel as far as sigmoid colon where the sharp cutoff and no gas in rectum. So which one of the most appropriate investigation? Tell me, doctors. Tell me. Okay. Okay, so CT abnormal. I hope you get an idea about CT, right? Get an idea about CT. Okay, now the problem is here. Yes. We'll go back to our question. So, patient present with vomiting, abdominal distension, and groin swelling. Previous history of appendectomy many years ago. What is next best step? So, what do you think in this scenario? Is it CT or surgical exploration? Anyway, ultrasound is out. So, what do you think from these two? What do you think from these two doctors? What do you think? Tell me. What do you think? Is it surgical exploration of okay groin? What about other doctors? Okay, and just try to we'll try to find something. Just tell me your opinion. What do you think? What do you think? Mm-hmm. What about other doctors? Okay, here there can be two things, right? There can be two things for this obstruction, right? This bowel obstruction. So one is what? Adhesions from this small bowel obstruction, right? One is from that. Then they have mentioned something groin swelling. If this groin is incarcerated or strangulated, that can cause the obstruction. But here, just a groin swelling, right? Just a groin swelling only. Is it incarcerated or not? Tell me, doctors. Is it incarcerated or not here? Tell me, tell me. Tell me, is it incarcerated or not here? Just groin swelling, right? If it is incarcerated, how it present? How it present? Yeah, here the vomiting and distension, it can be due to yeah, is vomiting and okay, that's the two thing, doctor. Vomiting and abdominal distension from it give the idea about the bowel obstruction, right? And the abdominal distension. Then the groin swelling is present, right? So what are the local features that if there is a incarceration here? What are the okay the local how it is incarcerated? How local it present? If it is incarcerated, is it symptomatic or not? Patient present with how? Painful, right? The area, the bulge, the this swelling is painful, right? It's a painful, mainly the painful and redness also present, right? If it is incarcerated, those features also can be present, right? Yes, no coffin pulse, non-reducible, right? Non-reducible, yes. Those things can be present. But here the patient is having history of appendectomy many years ago. What is next best step? So in that case, the most priority should be what? Most priority should be the vomiting and abdominal distension, right? So what do you think in this case? What should be the priority? is a bowel obstruction of the thinking about the think about this swelling we can think about later, because at the moment there's no features of the local erythema or pain or anything, but it's here it seems like appendix due to these past appendectomy adhesive obstruction, right? It can be due to adhesive obstruction, right? Because there's just only with the groin swelling alone is not prove incarceration, right? Or there's obstruction, right, doctors? So because if it is incarceration, they will give it irreducible, right? And severe groin pain, right? Skin erythema, the tenderness, right? Those things or can be associated with the severe cases like peritonitis, like, but mainly it should be give irreducible, severe groin pain, and the skin erythema, the local features, and everything should be given if it is the incarcerated hernia, right? But here it seems like mainly from the adhesive one. First of all, you have to get an idea about what idea about the obstruction, right? Idea about the obstruction. In that case, if the CT is the available one, so we can go with the CT abdomen, right? Is it understandable for you? Understandable. Okay, if the stem is given, even though if the appendectomy or those things, appendectomy also present, and they have given the scenario like this: patient present with vomiting, abdominal distension, and painful groin swelling, and this groin swelling is irreducible, and the skin is also red, and like local tenderness, those things. In that case, that also that is a emergency, so in that case you need to go with surgical exploration, right? In that case you can go with the surgical referral or urgent surgery, right? Because the obstruction and the strangulation both present. But here, just groin swelling is not enough to diagnose it as the incarcerated or not, right? Because of that, here better to go with CT abdomen. Is it understandable for you all, or still doubtful? Tell me, doctors. Is it still okay? Is understandable or still doubtful? Okay, right? Okay. Sorry for that, doctors. My dog is giving me such a pain. He just entered my room. Okay. So yeah, CT abdomen, right? Here also the small explanation. And please read these questions as well. And please, okay, I'll show something for the no, for the herniation. So don't mind the background noises, doctors. You know my dog is in my room at the moment. That's why she is making some noises. Okay, I'll show, then your doubts will be clear. Okay, so obstructed her. Oh no, not this one. Oh, I think I know. I'm not going to read the whole scenario, but I want to show. Mm, no, not this one. Yeah, is it increase in colic abdominal pain, medical history of laparotomy, colectomy for, and she examination. She appears uncomfortable. Pulse rate is 95. Abdomen is distended. General tender with low pitch. There's a fullness in right groin. There's a fullness in right groin, right? Yeah. Okay, we'll do this question. I think this is okay here. A previous 65-year-old woman present with a 2-day history of colic abdominal pain. The vomiting has not been able to tolerate oral intake for 24 hours. She has a history of chronic kidney disease, hemolysis. It's also not very good. The bowel sound are increased and tinkling. The groin has 3 centimeter tender swelling immediately below the lateral to the pubic tubercle. The serum biochemistry is given here. So urea 16, creatinine 157, GGTP 349, AST 50, or 46. Which one of the following most appropriate initial diagnostic investigation? So now tell me the answer for this question. Tell me the answer for this question. What do you think, doctors? Okay, we will go back to previous question. But tell me the answer for this question. There is a 3 centimeter tender swelling as well. Woman present with a 2-day history of colic abdominal pain with vomiting, not being able to tolerate oral intake. So tell me, what do you think? Type your answers in the chat. Quickly type your answers in the chat. What do you think? What about other doctors? Doctors, tell me your opinion. Can you see like they can twist it, and because that's why you need to understand the concept properly. Okay, here they are given ultrasound. Let's see why. Because we are going to learn something new. Like the patient present with 2-day history of colic abdominal pain. 2-day history, not the acute vomiting, and the physical exam suggestive intestinal obstruction. The diagnosis is supported by the finding in increased and tinkling bowel sound paired with the 3 centimeter swelling in the right groin. The location of the swelling below the lateral to the pubic tubercle consistent with the incarcerated femoral hernia, because they are mentioning the tender, right? Tender, tender swelling, right? Here they are given the tender swelling, and it's consistent with the incarcerated femoral hernia. The experienced clinical clinician will appreciate that the tenderness of the swelling implies like ischemia, and the patient need to prompt surgical intervention. In such hand, any form of imaging will be superfluous. So, however, the real life in this patient here, they appreciate they will tell surgical intervention in that case, but then they are telling again in real life, in the patient will go through a number of investigation leading to the final decision making. Most patients with intestinal obstruction present acutely with abrupt onset colic abdominal pain, nausea, vomiting, and abdominal distension. The most important risk factors for an intestinal obstruction: abdominal or previous surgery, adhesions, wall or groin area, abdominal wall or groin hernia, inflammatory diseases like ulcerative colitis, then GI malignancies. The first consideration in the patient like this is a physical examination. After the examination, it's been completed. A lab evaluation should be okay. So then, patient who present with the significant abdominal pain, laboratory evaluation typically include the complete blood count. Okay, although not specific for the diagnosis. Then yeah, blah blah. And it is a patient has been vomiting with a poor oral intake. The only investigation required will be some baseline lab investigation. It is highly likely that patient require intravenous fluid replacement prior to the surgery, and need will be guided by the serum electrolyte picture. Although intestinal obstruction may be suspected based on combination of clinical examination, finding various risk factors, okay, and usually require confirm the diagnosis and identify the site of obstruction. The preferred imaging modality to confirm the diagnosis of intestinal obstruction is CT. Okay, we know that. Abdomen and the pelvis with contrast. Okay. To confirm this, the serum biochemistry shows the impaired renal function, and this would exclude any contrast studies. Okay, in this patient, you should exclude, and here they have given CT, just CT abdomen, not the contrast one they have given. Okay, while imaging is often essential part of the workup, suspected bowel obstruction, the cause of the suspected intestinal obstruction Evident in this case, obstructed femoral hernia. A plain abdominal X-ray would confirm the presence of intestinal obstruction, but would not define the cause. In this case, the ultrasound examination of the groin would be confirm the presence of the femoral hernia. This imaging investigation can usually be done at the emergency setting, and it is more convenient than a plain abdominal radiograph or CT scan, and these circumstances would provide all the information that is required while the urine non. So any emergency imaging investigation is to be done in case of intestinal obstruction due to an abdominal wall hernia, then ultrasound will usually be the most expedient, right? The good one. Yeah, yeah. Previous initially, doctor, they in the previous one they are telling initially you can go with the CT. Then here they are giving to confirm it. Better to go with CT IV. Let's see. This is updated in last month. That's what I have not seen. Yeah, because otherwise, like the all the hernia part, I covered soften. Yeah, just swelling, doctor. In our case, just swelling. Just swelling. That's what I told you in there, just swelling. Yeah, here swelling. Okay, you're asking about the previous e-medicine. That's a fullness, groin fullness. Okay, we'll do that question as well. So what you learn from this question, this is last month updated question. This is a good one. So what you need to do in this case? Yeah, we will do. First, tell me what you have learned from this question. Because this is the last review last month, that means this can be a new update something. Doctors, don't worry, I will do the previous question. Okay, for now tell me, uh, first tell me what you have learned from this thing. Okay, so here they have done the ultrasound. Why ultrasound? Not for the obstruction. The first thing you need to understand is ultrasound, not for the obstruction, right? So we are not doing the abdomen ultrasound, not okay. So we are doing here the ultrasound of the lung. Why? Okay, the presentation is for stable. Okay, so think like this. In here they are giving the thing is okay. You have to understand the bowel obstruction risk causes they have given. Okay, here firstly they have given those things in the that they are mentioning to understand the bowel obstruction. Initially, you can do the plain X-ray, but the better one is CT. Right, CT, and here again they have mentioned to confirm it properly. The IV, CT IV contrast city is the better. Then again, then they have telling if the incarceration present. So in our this case, they are clearly given incarcerated hernia because tender swelling, tender 3 centimeter swelling present, right? In that case, they're telling it's associated with this bowel obstruction. In that case, you have understands the bowel obstruction. Then to confirm the hernia, the incarcerated hernia, in that case, you can go with ultrasound, right? Ultrasound, this is the like practically we are using that, and but here they have clearly mentioned the surgical here, and like the ischemia here, the experience of clinical will appreciate the tenderness of this swelling impress like ischemia, and patient need prompt surgical interventions. Okay, in like such a hand, any from the image will be superfluous, right? So okay, if they have given like what is most appropriate next investigation, in that case what you should go most appropriate next, most appropriate most appropriate next management, most appropriate next step in management. In that case, what you prefer? If the answer is given, the surgical interventions refer for surgical surgery as well. In that case, what you should prefer? Still, you are going with the ultrasound, or you are going with the surgical referral. What do you think? In that case, what do you prefer? Yeah, in that case, go with surgical referral because that is the most famous e-medici question. Okay, most famous, not e-medici, the AMC exam question. If you see an incarcerated hernia, you must refer for urgent surgical referral. You should do. Okay, here they are asking something different. They are asking what is most appropriate initial diagnostic investigation. They are asking about investigation, right? Because of that only we are going with ultrasound. Okay, here they very clearly mention. I will attach this question. Okay, I will attach this question. First of all, I will minute. Okay, go to the 1 minute. Go to previous question. Okay, I don't know this. Okay, so this question, do this question, tell me the answer, then we will discuss. Okay, then we will discuss. Okay, here's the question. 92. ED, 24-hour history of increase in generalized colic abdominal pain and vomiting. She has a medical history of laparotomy and colectomy for colon cancer 10 years ago. She take paracetamol as needed, but no longer medication or regular medications. Examination, she appears uncomfortable. Pulse rate is 95, BP 135 by 85. Respiratory rate is 20, SpO2 98. Temperature 37.2. Abdomen is distended and generally tender with a high pitched bowel sound. The fullness in the right groin. So CT images is given here. Okay, so they're asking which one of the following most likely diagnosis. Now tell me, what do you think? Okay, so do you want again the question? This is the question, and this is the CTG images. Now tell me, what is the answer? Tell me, doctors, what do you think? Then we will discuss this question as well. What do you think? Okay, what about other doctors? Quickly answer, doctors. Please give some your opinion, then we will discuss, okay? Because can you see the time? It's 5. You are taking too much time. So that's what we can't finish the records properly. Because of that, please type your answers here. What do you think? Just simple question. You can type. You don't have no one here to judge. We all are here to, but you all are here to learn something, right? So that's what. Okay, you all going with femoral hernia, right? 4. Good. CT image demonstrate the knuckle of small bowel herniation through the femoral canal, which is lies below the lateral to the pubic tubercle. This finding combined with the clinical presentation of colic abdominal pain and vomiting in elderly women diagnostic of femoral hernia. Right? Here. Okay. So then, what they have given the femoral hernia, more common in elderly women, carries a high risk of incarceration and strangulation due to the narrow, rigid femoral canal. The typical presentation as a lump below the lateral to the pubic tubercle. Through this finding may be subtle on examination. This case highlights the importance of to the physical examination in elderly patient with presenting the abdominal pain as well as value the CT images confirming the diagnosis when clinical findings are equal. Right? So, physical examination groin essential to elderly patient presenting with abdominal pain, refer for the bowel obstruction. CT can identify the type of location of hernia when physical examination is unclear or incomplete. Yeah. Yeah. Okay, can't our recall question be like this? Yeah, can it be right? Okay, so what is in here? So if you saw these two previous two questions, what was in your mind? Email is also given. So here, let's see. This is the last year updated. Okay. Okay, here, 74-year-old woman present to the ED with 2-day history of colic, abdominal pain, distension, and vomiting. She has a medical history of hypertension, MI, with stent 2 years ago, appendectomy 22, medication include clopidogrel, aspirin, perindopril. No relevant social or travel history. On examination, she appears unwell with pulse rate 100. BP 140 by 90. The respiratory rate is 80, SpO2 98. Then temperature 37.2. Soft distended abdomen with high pitched bowel sound. There's easily reducible and non-tender right inguinal hernia. The good question, plain abdominal radiograph show the dilated small bowel loop with air fluid level. So which one was most likely cause of presentation? You are a life savior, Dr. Ritik, all the way. You can easily find the questions, right? So yeah, I have 3 questions to attach. So can you see if this kind of presentation given it's totally adhesions right here? The same theory that I told you, if it is reducible and non-tender, it's just a normal swelling, it's not the incarcerated. But if it is tender or with not reducible, right? Then erythema, tenderness, those things is incarcerated hernia, right? Yeah, that's a good question. Okay, I will attach all of the questions there, these 3, right? This one as well. Okay, and other question as well. Now your task is do all the questions today, okay? All the questions today for these incarcerated hernias and everything. Okay, no, okay. I'm not wasting too much time on this. Okay, I'll attach here. Other two, I will attach it, okay, doctors? So don't worry. Other two, it's a long question and I need to add some a note for that. So attach. Okay, so our question is just a groin swelling. They have not mentioned anything. So in that case, we can go with CT abdomen because the next they have not done anything here. Just we had to find out the is the bowel obstruction present or not because we are suspecting one, right? Oh, yeah. Okay. So we'll move to the next question. So mind blowing, right? Yeah. Mind blowing, right? Now they are adding some very weird type of questions, right? So that's what you need to concept, right? Concept, other than it's very hard you to understand, right? Okay, now I'm going to ask a question. There's a okay, there's a swelling. Uh, Nothing present with the bowel obstruction, just a swelling. Okay, just a groin swelling, and it is a reducible, no pain, no swelling, just a reducible groin swelling. Okay, so what is the management? What you need to do? So on this ultrasound, refer for surgeon. So what do you think? In that case, are we doing anything or like X-ray or whatever? What you need to do? like those things. Surgical referral. Surgical referral, right? Surgical referral, because not for the urgent surgical referral, but there is a hernia present, right? Even though it's a reducible hernia, there's a herniation present. In that case, the most appropriate management is to refer this patient, right? To refer this patient, because later, just a referral, okay? Then surgeon will decide their management and everything later, right? Like that. Okay, how you feel about the new medicine part about the ultrasound? Can you see the last month? I don't know what is with them. CMED says I didn't like so many questions, right? Okay, next one. Patient has serum sodium 127 and urine sodium 400. What is the most appropriate management? First of all, diagnose this and the type you answer. Answer and the diagnosis. Quickly answer. These are Mary calls. Mary calls topics, okay? Most of Mary calls topics are repeated in here. Mm-hmm. Okay. Mm-hmm. Okay, we'll do this question. We'll do this question and we'll discuss. Okay. A 25-year-old man presented the ED after falling off his bicycle and sustaining head injury. He's admitted to the surgical ward for observation. 3 days after his trauma, he is alert and oriented without headache. He has been eating and drinking normally. He has no significant medical history and does not take any regular medications. On examination, he appears well, pulse 80 BP 120 by 75, CO2 98, 37.2 temperature. Urinary catheter is in place with urine output 260 milliliter over the last 6 hours. He is receiving intravenous Hartmann solution 2 liters over 24 hours. So, blood test sodium 127, potassium 3.5, chloride 104, bicarbonate 26, urea 2.8, serum osmolarity 265. Then urine sodium. Okay, urine sodium is 85. So what do you think? Okay, sorry, they're asking which one of the most appropriate next step in management. So what do you think? What should be the answer? Many doctors here have done the Mary calls with me. So you should remember this topic is easy topic, right? Okay. What about other doctors? Quickly, easy question. I'll explain, don't worry, okay? But tell me your opinion, what do you know? Because everyone know about this disease, right? You don't need to learn it again. Okay, here. Patient present with the features consistent with SIADH, syndrome of inappropriate antidiuretic hormone secretion. The diagnosis is supported by euvolemic hypertonic hyponatremia, the low sodium and osmolarity, right? Inappropriately high urine sodium and normal renal function in the context of recent head trauma. The patient is clinically euvolemic with the normal vital signs and adequate urine output, which help distinguish SIADH from cerebral salt wasting, where patient typically present with hypovolemia, right? So fluid restriction is most appropriate first line treatment for SIADH in clinically stable patient. By restricting fluid intake, the excess water retention is gradually corrected, allowing the serum sodium to normalize, right? And this approach is safe and effective, and particularly when the hyponatremia is mild to moderate and the patient asymptomatic, typically fluid restriction to 500 to 1 liter per day as recommended, right? Okay, so when you should give intravenous saline 3%. Yes. 3% hypertonic saline. When to give 3% hypertonic saline? Tell me, doctors, when to give 3% hypertonic saline? Yes, in severe cases, right? I will explain. Okay, we'll do this question and I will fully explain the topic. 73 or more percent of the ED. 3-day progressive confusion and mild drowsiness. He has a metastatic small cell lung cancer diagnosed 2 months ago and currently receiving chemotherapy. He has no significant medical history, no regular medications, examination. He is euvolemic, pulse 82, BP 128 by 78, respiratory rate 16, SpO2 96, and the temperature 36.7. He is confused and disoriented to time and place, but respond appropriately to the verbal command, and there are no focal neurological signs. So sodium 118, potassium 4.2, serum osmolality 248, urine osmolality 520, urine sodium 65. They're asking which one of the following is most appropriate first line management. Now tell me, patient present with the focal neurological, no, he's confused and disorientated, and the sodium level is less than 120. So in that case, what you need to give 3% hypertonic saline, right? Patient present with symptomatic hyponatremia due to the syndrome of inappropriate antidiuretic hormone secretion. And this is common paraneoplastic complications of a small lung cell carcinoma, right? The small lung cell carcinoma. So, 3% hypertonic saline is a reasonable first step in management given the neurological features including confusion, disorientation, and drowsiness. Also, the maintained when the patient present with seizure, coma, or severe altered consciousness, hypertonic saline allow for the rapid improvement, but caution must be exerted. 1 minute. Yeah. So remember, okay, so now you have two things. Okay, mild, moderate, asymptomatic, or minimally symptomatic SIDH fluid restriction, severe symptoms, or if it is the sodium level is less than 120, 3% hypertonic saline with careful monitoring, right? So general idea. So now tell me what is this SIADH? What is this SIADH? So what is happening in here? So what is happening in here, doctors? What is happening in here? SIADH. It's excessive, right? Inappropriate ADH, the vasopressin, right? Is released despite of this normal plasma osmolarity, right? So what is happening here is that there's a too much ADH. So ADH function is water retention. So increase the water retention and dilutional hyponatremia can cause, right? Right, doctor? So simply the pathophysiology, how it happened, ADH is increased, right? Then kidney reabsorb but more water, right? Then after absorbing more water to the towards the blood, then blood become diluted, right? Blood become diluted. Then what is happening after that? So sorry, because of that sodium, the serum sodium level is decreased because of the dilution, right? Dilution, then what is happening, then body excretes sodium in urine to maintain the volume, right? So high urine in sodium because of that. So key finding in here, what are the key finding? So serum sodium here, SiADH. So serum sodium is reduced, right? Serum sodium is reduced. Then serum osmolarity also reduced. And what about urine sodium? Urine sodium here high, right? To compensate, they are removing sodium, right? Yeah, they are excreting sodium in urine to maintain this volume balance, right? Because of that, urine sodium is high, right? And urine osmolarity is concentrated, right? Because this more more sodium in urine, right? Because of that high osmolarity. So remember, urine high, serum low, right? Remember like that. Low serum, high in urine, right? Remember. Then it's easy for you. And there's a no edema or no dehydration, right? So usually patient is euvolemic in this case. So I have attached DI as well, the diabetes insipidus. That's something different because the most of the time they're asking to differentiate these two. That's why I have attached. Okay, so that is what happening in here. So now let's discuss about the causes. So what are the causes? Causes can be what? It can be CNS causes, right? Can be cancers, right? There can be so many things like small cell cancer, right? There can be due to strokes, these meningitis, head injuries, right? Or there can be associated with the drugs as well. Like what are the drugs? This carbamazepine, SSRI, those things. Okay. So mild symptoms are like headache, nausea, vomiting. Those things can be seen. Moderate confusion, drowsiness. But if it is a severe one, this seizures, coma can be associated, right? If it is mild or asymptomatic, you can go with the fluid restriction here. So his serum osmolarity low. Then assess fluid status. So euvolemic here also they have given what is happening and everything. Okay, so you can give it a read. Like this is all for the hyponatremia. I have attached as extra thing. But for this, it's a ADH, so mild or asymptomatic fluid restriction. Right, then if it is a severe symptomatic patients, or if the point that emergency has given, if the sodium level is less than the serum sodium less than 120, in those cases what you have to do, you have to go with 3% hypertonic saline, right? 3% hypertonic saline is a very important thing. Yeah, that's all for this one. Yeah, that's all. Okay. Okay, doctor. So we will take a small break. Okay, 5:23. So we will meet at 5:30, right? 5:30, a 7 minute break. Right? No, 8, no, 7, right? Okay, so then we will continue. Okay, I just turn on the recording. Okay, so here serum sodium 127, urine sodium 400. What is the most appropriate management here? They have not given anything. It seems like this kind of question, right? It can be the same question, right? It can be the same question. As you know, emergency question, they are given in the exam as well. So what you can do, they have not mentioned anything about the symptoms or everything. So what you can do as the fluid restriction, right? Fluid restriction, right? Okay. So the next question. Next one, strep throat, penicillin allergy, but antibiotic. Cephalexin, erythromycin. We have done this question, right? We have done this question, right, doctors? The strep throat question. We have done, right? Now tell me the answer. Okay, tell me what we can use if the patient is having penicillin allergy for strep throat, streptococcus. Tell me, doctors, we have discussed, we have went through the RCH chart, right? What is they have given the option in the guideline? What is the option they have given here? Cephalexin, right? Cephalexin. Here, if it is a non-severe immediate or non-severe hypersensitivity, you can use cephalexin. If it is a severe hypersensitivity reaction, you can go with azithromycin, right? So answer is cephalexin. We have discussed this, doctors, like multiple times in past sessions. So yeah, next one, Erythrasma at elbow, so we don't know the question. Okay, we don't know question. We don't know the question what they are asking, but I have kept it. So low back, we have discussed everything about this erythrasma. So lower back pain, breast cancer, decreased power and reflexes in lower limb. Next best step, MRI. The only option given. So what you can do? Tell me the stepwise how you should manage this patient, because I have explained this kind of scenario. If the patient is presenting with decreased power and reflexes of lower limb, right? So associated with red flags, right, doctors? So what you can think about in here? Tell me, doctors. Okay, you are done. You have done MRI or CT. You have done something, and you have a radiological proof as well, and the clinical presentation also given the cord compression from the metastasis cancer. Okay, in that case, what you need to do initially? Have you remember? I have explained. Okay, I'm not tell you. Just go and check those questions. Okay, because you have not repeated the things. You remember the question that we have done? That we have done. No, I have not attached it again. Yes. Corticosteroid in which patients? Corticosteroid in which patients? Do you remember we have done the question? Question for what? Question prostate cancer with this metastasis. Metastasis cord compression. Metastasis to the cord, and the cord compression happened with the neurological symptoms, and they have confirmed it with the in the question. Okay, not in the this case. In that question, they have confirmed it with the CT as well. So radiological proof also there, right? Radiological proof also there. Then they are asking what is the immediate management. No, doctor, radiotherapy is not the immediate management. That is a definitive management for the pain. That is later. But the immediately you have two options. You can go with IV steroid or IV corticosteroid, or you have the surgical decompression, right? You have surgical decompression. So if the patient is a good surgical candidate, you can go with surgical decompression. Otherwise, if the patient is elderly and with other comorbidities, you can give the IV corticosteroid, right, initially. So I remember, but you are not remembering those things. Why? Yeah, those things very important, okay? So stepwise, remember these things. So these are the key features: history of malignancy, then breast, prostate, lung, the new or worsening back pain, limb weakness, sensory changes, reflex abnormalities, bladder and bowel dysfunction. So immediate MRI, right? Radiological confirmation, start dexamethasone, urgent neurosurgical spine decompression surgery. Like it's depend on the patients. Okay. Yeah. So here we'll do this question. Seven. This is yeah. 77-year-old man present to the ED, tertiary referral hospital, trauma to a lower history of acute mid-thoracic back pain. He was recently diagnosed with prostate cancer and has an appointment with his urologist a few days ago and discussed the treatment option. So the back pain was sudden onset, worse with the movement, and not associated with the sorry, associated with the trauma or force. He reported no bowel or bladder dysfunction. He has a medical history of hypertension and type 2 diabetes, and his regular medications are amlodipine and metformin. He lives at home with his wife, fully independent with all activities of daily living, and maintain active social life. Examination, he appear well. Pulse rate is 78. BP 138 by 82. Respiratory rate is 16. Oxygen 98. Neurological examination revealed mildly reduced power in the lower limb, intact sensation to light touch, and pinprick throughout. So normal proprioception is symmetrical. Deep tender reflex, upper and lower limb plantar reflexes are down going bilaterally. There are no clonus. Romberg sign is negative. Gait is normal. The only other positive finding is severe mid-thoracic back pain in palpation. They ask in which one of the following is most appropriate. So most appropriate is what MRI of the whole spine. Why? Here, the patient is having new metastatic lesion in the thoracic spine and the potential development of metastatic spinal cord compression. Right, this is not the cord compression situation. This is before that, right? At the moment, it's not compression present, right? If the compression present is the patient is severely unwell looking, right? So then MRI of the whole spine is a gold standard. Gold standard is MRI to detect in the spinal metastasis and evaluating the spinal cord compression. It provides excellent soft tissue contrast and can detect bone marrow infiltration before any body destruction is visible on the other imaging modality. Eye detection is crucial for timely interventions and prevent complications. So why not CT? So prostate cancer obstructive symptoms. They are asking next best step for the obstructive symptoms, right? For the obstructive symptoms, not for the prostate cancer. Can you see the options they are given? We have to assume the patient is already taking medication for the prostate cancer because they are asking for the obstructive symptoms. So these are low urinary tract symptoms, right? We have two types of symptoms: voiding symptoms and storage symptoms. Voiding symptoms are obstructive symptoms. Hesitancy, poor stream, intermittent flow, incomplete emptying, post-voidal dripping, or flow incontinence. So storage symptoms are frequency, nocturia, urgency incontinence. The complex symptoms, hematuria, recurrent UTI, acute chronic urinary retention, urinary incontinence. So here's storage symptoms. Due to urinary tract infection, bladder calculi, urethral carcinoma of reactive bladder for voiding symptoms, the obstructive features due to BPH or bladder neck stenosis, urethral stricture, poor detrusor contractility, right? Okay, so here we'll do some question. We'll do this question. We will go back to our question. 73-year-old man is referred to the urological clinic with 1 year history of worsening urinary symptoms. He get up for 4 times each night to urinate. He has a weak urinary stream, hesitancy, and sensation of incomplete voiding. He does not have any other urinary symptoms. His medications include hypertension and osteoarthritis of the knee, for which he takes perindopril and diclofenac. He drinks a glass of wine more evening. On examination, he appears well with vital signs within normal limit. Examination revealed no tenderness or palpable bladder. Digital rectal examination revealed a smooth, symmetrical, enlarged prostate with no nodules. Urine analysis is negative for blood leukocytes and nitrites. His prostate specific antigen 3.2. Ultrasound shows an enlarged prostate of 55 with noticeable middle lobe enlargement and post-void residual 85. Which one of the following appropriate management of plan? Now tell me the answer. What do you think, doctors? Tell me the answer. Type your answers in the chat quickly. Mm-hmm. Okay, what about the doctors? Only Dr. Sandali and Dr. Tasneem is here. Okay, Dr. Ritik also shared. Okay, let's see here. Patient present with the LUT symptoms, low urinary tract symptoms, consistent with BPH, right? Here, consistent with BPH. Symptoms include nocturia, weak stream, hesitancy, and incomplete voiding. The obstructive features are here, right? Then, an enlarged prostate 55 with middle lobe enlargement and significant post-void residual volume 85, right? Okay. So, tamsulosin is an alpha-1 adrenergic receptor antagonist that relaxes smooth muscles in the prostate and bladder neck, improving urinary flow. The patient should be given a trial of tamsulosin while it can be effective for mild to moderate BPH symptoms. and it is less likely to provide adequate relief. This can be given significant middle lobe enlargement and elevated post-void residual volume. So alpha blockers generally work best for the functional rather than mechanical obstruction. Okay, so let's see about tamsulosin and dutasteride. Combination therapy can be more effective than either medication alone, right? For moderate to severe BPH, however, given in this patient significant midlobe enlargement and elevated post-void residual volume, the medical therapy is less likely to provide the adequate symptoms relief comparing the surgical intervention. So, however, trial period with tamsulosin would be appropriate, right? So here BPH, hyperplasia, significant middle lobe enlargement often respond better with the surgical intervention. So that is for the BPH. Okay. So post-void residual volume 80, more than 80 milliliters with the moderate severe lower urinary tract symptoms is indicated of the surgical management. That is also for BPH. So transurethral resection of the prostate remain gold standard for surgical treatment of moderate size prostate. So this is a very important part for you to remember for this BPH. But our question, we don't know just prostate cancer. They are not mentioned benign or like that, but they have mentioned something about the prostate cancer and the urinary problems. Okay, here. Then again, I'll explain from here. For alpha blockers, when to use? Alpha blockers are used to treat void in the obstructive symptoms and may improve urinary flow, although ineffective prostatic size reduction. Ineffective in prostatic size reduction, right? Not treat for the size of the prostate, it's treat in the void in symptoms, right? The symptoms, hesitancy, right? Those things. And they block prostatic alpha 1A adrenoreceptors to cause the prostate smooth muscle and bladder neck relaxation. They can also have peripheral and central nerve system efficacy similar between the selective and non-selective medications. Okay. Then antimuscarinic therapy. Antimuscarinic therapy is treat for the storage symptoms. I mean, give me 1 minute, doctor. There's another one important question for this one. Yes, another question. Okay. So antimuscarinic drug treat, this is for storage symptoms. Okay, here medical therapy, alpha blockers, antimuscarinic, so 5-alpha reductase, those things you can use. That is for the treatment. Okay, the virtual waiting and behavioral modification, medical therapy. Under that, you can. This is for lower urinary tract symptoms. Okay, ablative treatment, transurethral microwave therapy, transurethral needle, those things. Okay, so the cavitation, that is not the prior to relieve the urinary obstruction. So for voiding symptoms, alpha blockers you can use. For the retention, you have to use the catheterization. That is something different because it also can be given associate with that, right? Associate with that. Okay, so just to show some idea, I attached that one. So here, prostate cancer obstructive symptoms. So obstructive symptoms is present. So what do you prefer? Obstructive symptoms present. What do you prefer, doctors? Is oxybutylene patch is preferred or not? Oxybutylene patch, it is for what? Which symptoms? It is for what, doctors? Tell me. It's for obstructive symptoms or something else? It is for storage symptoms, right? It is for storage symptoms, but here the problem is obstructive symptoms. So what you can give as a medications? What are the medications you can give? The best one is what? First line medication is alpha blockers, right? Alpha blockers, right, doctors? So alpha blockers are the first line medication. So you can use tamsulosin, right? Those drugs. Right, doctors? Okay. Now tell me where we should add those dutasteride, finasteride. So what is the reason of adding dutasteride and finasteride? Okay, so tamsulosin, the alpha blockers for the obstructive symptoms. So when we should add, okay, yeah, sorry for that. So when you should add those dutasteride or finasteride? When? What is the reason of adding those drugs for this tamsulosin? What is the reason? I have explained this in November recall session and other sessions as well. I can't remember the exact, but November I have a separate note as well given. When to add? Yes. Yes, to reduce the prostate volume, right? Once you need to reduce the prostate volume, in that case, you have to add these 5 alpha reductase inhibitors, right? Like that. Okay. So yeah, so alpha blockers for what? For this obstructive symptoms. So answer should be look for the alpha blockers like tamsulosin, right? Doxycycline. So like that because they are acting and relaxing these prosthetic smooth muscles and avoid prevent these obstructive symptoms, right? And if there is the case that we need to reduce the size in that case, we can add these 5 alpha reductase inhibitors, right? Yes. Okay, so that's all. So here what you should look for, you should look for alpha blockers. Okay, I hope you get the idea, right? Okay, so like that. So acute limb ischemia management. Tell me the acute limb ischemia management. Easy question. It is in the chat. Yes, okay. Yeah, yeah. Yeah, doctor, there's a criteria that is under the topic of BPH, right? Yes. Please do the email question, then you will find not for this at the moment our question because that they are asking only for the obstructive symptoms. Okay, so peripheral artery disease, so acute limb ischemia. So what is acute limb ischemia? So acute limb ischemia is presented with these symptoms, right? So we have 6 P's: pain, pallor, pulselessness, poikilothermia, or we call it cold limb, and paresthesia, the sensory loss and paralysis, late indications of threatened limb, right? And these symptoms are sudden onset symptoms, right? Severe limb pain, numbness, or tingling and weakness, or inability to move the limbs. Remember these things. Additional signs: sudden cold, mottled skin, a rapid deterioration over hours, and limb may be tender and rigid if irreversible, right? So these are the features. Okay, so I'll show some questions. We do that one, then you will answer it correctly. Okay, here. 79-year-old man present to the ED with 3-hour history of progressive worsening pain in the right forefoot with associated discoloration of the toes and the mild reduction of the motor function of sensation. And this is his first presentation of sharp pain which occurred while at rest and the worst on movement. Minute. Okay. Was on the yeah. This is the first episode. Then sharp pain which occurred while the rest and was on movement. His medical history include hypothyroidism and hypertension, for which he takes carbamazole and perindopril. On examination, he has a irregular radial pulse 140 and blood pressure is 138/75. Other vitals are within normal limit. There are no signs of trauma. His right foot is cold and pale. Capillary refill time is delayed, and there's a reduced venous filling in the foot. So the right femoral pulse is easily palpable. The right popliteal, dorsalis pedis, and posterior tibial pulse are absent. The patient has slightly reduced movement of the toes and therefore with preserved ankle and knee movement. He also has a mildly reduced sensation in the toes. Oxycodone is given for the pain. Which one of the following most appropriate next step in management? So what do you think? Answer is marked. So intravenous heparin. So acute limb ischemia surgically requiring prompt vascular input. Intravenous heparin should be commenced as soon as practical to prevent the further local systemic complications. Early vascular consultation should be done by management in the investigation should be carried out, including routine blood check, venous blood gas for the lactate, and the ECG, Doppler ultrasound, and potential CT angiography. So the definitive treatment depend on the lymph viability, right? So this criteria, what we call the treatment depend on the proper treatment depend on this criteria, right? We call it Rutherford classification. Right, Rutherford classification, because this first time they have asked in October 2025 exam, and now after that they are usually asking for this one. Because of that, you need to get the idea how these classification presents the class 1 viable, class 2 marginally threatened, and class 3 immediately threatened, and class 3 mean irreversible damage can be occur, right? Sensory impairment, motor impairment, arterial Doppler sign, and venous Doppler sign. According to this, you are choosing it, right? You are choosing the what to do, right? What to do on. Yes. So we are using this one acute limb schema to assess limb viability to guide how fast vascular team must intervene and choose the type of revascularization. Because we have endovascular, open surgery, or amputation, right? If the patient is in class 3 and it is irreversible, so sensory anesthetic, motor impairment, paralytic or rigor, and arterial Doppler sound inaudible, but venous audible, but it doesn't matter. And the damage is irreversible. That means the leg is not viable. In that case, you have to amputate it, right? Like that, you need to decide. Okay, you need to decide like that. Okay. I hope you get an idea about this thing. I will attach the this thing. So a patient presented with those 6 P's and other symptoms. If you are suspecting it, you need to refer this patient for the immediate emergency revascularization. In there, you are giving the intravenous heparin and urgent CT angiogram you should done, because without doing CT angiogram, you can't plan the surgery, right? To plan the surgery, to get idea about the anatomy, you must do the urgent CT angiogram before the surgery. Then you can go with the treatment. It can be embolectomy or whatever related with the scenario, right? Like that. That is all for the acute limb schema. I will attach the note. Okay. After the session, I will attach. Okay, so next one, patient on mania having hypomania episodes on lithium decreased compliance. What to do next? Give lithium, olanzapine, risperidone, alprazolam, haloperidol. So what do you think? Quickly answer, doctors. Tell me, doctors. Tell me what do you think. Okay. Tell me what is your opinion. I'm just asking your opinion only, right? Okay, so in this case, what happened here? What is happening in here? First of all, tell me, have patient is a maniac patient, right? Patient is a maniac patient, right? On lithium. So when we are using lithium in mania treatment of the mania, for what we are using lithium for the mania treatment? When we are using lithium in mania, okay, okay, as a mood stabilizer for a long term management, right? To long term management, right? We are using lithium, right, doctors? And here they are telling what? And here they are telling what? They are telling lithium episodes and the hypomania can see now with the lithium is decreased, right? Lithium is decreased compliance. What to do next? Okay. So that means the here what is happening? Here what is happening? The acute hypomania, right? Patient on lithium, but lithium has decreased. Because of that there is a hypomanic relapse, right? Hypomanic relapse, right? Not severe like mania, but it's still hypomanic. Acute relapses can be, relapse is present, right? Okay, then so how you should treat this acute scenario? How you should treat this acute scenario? What is the treatment of choice for the acute control of the this mania or hypomanic drugs? Antipsychotics, right? Yes. Okay, let's discuss. Mhm. Okay, so here, patient on lithium. Stop taking the other question. Lithium level low. Next best step. Okay, before that, we'll quickly go through. Principles of managing acute mania in adults and younger people. Okay, patient, determine the severity of mania symptoms, right? First of all, you need to determine the severity. Anyway, if it is a mania present, you must urgently do the treatment, right? You have to hospitalize the patient because patient need urgent treatment. Then you have to assess the severity, right? Severity of the symptoms. That is another most important thing. Assess the severity, right? Assess the severity, right? Risk to themselves or others, psychosis present, severe agitation present, like need of admission, like everything you have to assess, right? Assess. Then impaired insight and judgment and risk causing significant harm to themselves, like the same thing that I just explained. Then determine whether the patient has engaged in uncharacteristic behavior and help them to address in any consequences of his behavior. So patients with severe symptoms of mania who are danger to themselves or other require urgent treatment in hospital. The primary aim uh, treatment is what? The disturbed behavior. I don't know what Kurt. Disturbed behavior, aggression, violence to stop. I think that think it has to stop the to cut down or something. Stop the disturbed behavior like this, overreactivity, agitation, violation, aggression, and antipsychotic is used to rapidly achieve this. Additional intervention may be required to calm the patient who are served agitated or are behaving in a threatening or aggressive manner. Start lithium sodium valproate or carbamazepine simultaneously with the antipsychotic here. So an antipsychotic start immediately to rapid reduce symptoms of mania. Use short term Use short term, stop once acute mania symptoms remit and the patient is euthymic, right? Okay, plus here you have to, at the same time, you have to start the lithium or sodium valproate or carbamazepine as a maintenance treatment. Start currently with antipsychotic, continue for 6 to 12 months to prevent relapses and consider prophylaxis is needed, right? So this is the management. So lithium, sodium valproate, these things. So lithium is the most effective drug for preventing relapses in mania. The sodium valproate carbamazepine are not as effective as lithium, right? To maintaining the relapses and all, right here. Okay, so lithium carbonate immediate release 500 to 500 to 100 1000 milligram orally daily 2 to 3 device doses are the single dose at night. And remember the target concentration 0.8 to 1.2 millimoles per liter, depending on the clinical response and tolerability. Right? Yes. Okay, acute mania summary. First step, assess the self-rest to others, just I discussed. Pharmacological first line rapid symptom control by antipsychotic, purpose rapid reduce agitation, aggression, inability, and maniac symptoms. The most stabilizer start concurrently and use ongoing control, lithium, sodium valproate, or carbamazepine. And you should continue 6 to 12 months after remission, right? So additional short-term medications we have benzodiazepine like drugs. In severe mania, patient can be present with violent behavior, severe agitation, risk to others. So management antipsychotic immediately. Add lithium or valproate. Consider hospital admission and ECT if refractory. So maintenance after stabilization. Once patient become euthymic, so stop antipsychotic regularly, sorry, gradually, and stop continue lithium because you already started in the acute situation and you can continue lithium, valproate or carbamazepine, right? I hope like overall the thing is understandable, right? What do you think, doctor? This is understandable, right? So we'll go back to our question and we'll discuss, right? What they are asking. Okay, here. So in this case, patient having mania, now hypomania episode, the relapse is present. In that case, what you need to do, acute situation is in that case, what you can give, what is the treatment you can give is antipsychotic. Now, what antipsychotic should we give? Olanzapine, risperidone, alprazolam, haloperidone. What do you think? What is the antipsychotic of choice? Tell me, doctors. Okay, I'll show what they have given the order. I think I have not attached it. How to treat acute situation. So why olanzapine? Why olanzapine? Why not the given other drugs? Okay, here we have olanzapine, risperidone, those drugs, right? Here the olanzapine. Maximum dose 30. Stop olanzapine once acute symptoms have remitted and continue with the lithium or sodium valproate or carbamazepine monotherapy. Risperidone, here also the same thing they have mentioned. Aripiprazole, then what else? Quetiapine. So the first line is olanzapine and risperidone, right? Risperidone is not given. Risperidone is also given. Then what you need to do? So from olanzapine and risperidone, what to give? What to give, doctors? What to give from olanzapine and risperidone? Tell me. Tell me. Okay, in that case, what you need to know in that case, the other thing you need to know about this patient's other features, like if the patient is presenting with the metabolic syndromes, like the adverse effect. That is the place that you apply adverse effect, right? Very important. I have attached, as I remember. Somewhere I have attached, but can't. Minute. Yeah, it's that. Okay, here. Then the drug should be designed according to the adverse effect, right? According to the adverse effect. Okay, here's the adverse effect. So, if the patient is presenting with cardiometabolic diseases like what? Diseases like the diabetes, overweight, right? In those cases, what we can give here. So we have what are the options given? Olanzapine, right? So let's take olanzapine. Olanzapine also having cardiometabolic 3 plus. When what about risperidone? Risperidone 2 plus. If the cardiometabolic effect from these two, the better one is risperidone, right? Like that. You have to decide according to their given features, right? Okay, like that. So some details are missing because this is a recall, right? Because of that, better to go with better to go according to the given scenario, right? That's what I'm not marking anything because both are both are the first line drugs, right? Both are first line drugs, right, doctors? Both are first line drugs. Is it understandable, right? Is everything it's okay, right? Okay, here. Olanzapine and risperidone both are first line drugs. It's understandable, right, doctors? So according to that only we have to decide. Okay, so what about the second question? Second question. So patient on lithium stop taking lithium. Lithium level was low. What is the next step? Lithium level is low. What is next step? Restart lithium or olanzapine. Patient on lithium stop taking lithium and lithium is low. Next best step. So now tell me what you need to do. What you need to do, doctors? Quickly answer. It's a very important question. Quickly answer, doctors. Then it's better for everyone. Yes, it's depend. It depend on the scenario. Okay. So here, low lithium levels simply indicate that there's not enough lithium in the body, right? So most commonly because why? The patient stopped taking, so because of the non-adherence or missed doses, or it was measured before the reach in the steady state, right? The concern is that lithium is no longer providing mood destabilization, so patient is at risk of maniac relapses, depressive relapses, or recurrence of bipolar disorder, right? So in that case, what you can do in here, if the patient is not having the acute relapses, right, and not having acute relapses, and the patient miss doses, or patient is non-adherence, we can restart the lithium. But if the acute presentation is given with the acute maniac symptoms given, you have to start the antipsychotic as well with this lithium, right? Yes. That is the way you have to think. Okay, that is the way you have to think. I hope this is understandable because these are very like a little amount of the recall stem is here. Because of that, you have to think accordingly. But in here, the hypomanic episodes present. In that case, you must give antipsychotic, right? Antipsychotic. But in here, if there's a nothing present like the acute symptoms or like maniac features, you don't have to worry. Then you can restart lithium because of the risk, because of the low risk level mean there can be you have to there can be a risk for the relapses, right? So you have to prevent it, you have to restart it, right? So that is the way of it. Right? Okay, so next question. I'll attach a small note.